Good afternoon and welcome to another episode in our CEO Engagement webinar series. I trust you're all keeping well, keeping safe, healthy, and that you've all had a good start to 2021. So today we're discussing the COVID-19 vaccination and more specifically the role of the private sector in supporting government with the vaccine rollout. I think given the magnitude of the task to vaccinate the South African population, the emergence of the more contagious South African variant, various other variants, and the most recent setbacks has suffered as a result of the Oxford AstraZeneca vaccine rollout being halted. The support of the private sector is going to be required at unprecedented levels. Business has collectively risen to this challenge through initiatives such as the Solidarity Fund and Business for South Africa. However, keeping abreast of this rapidly evolving space has been quite challenging for most of us. And it's been compounded by disinformation and a severe lack of transparency in government decision-making. So how should regional Western Cape-based business support the government-led national vaccine program? Is regional autonomy an option? There's been a lot of talk of a Western Cape vaccination plan. Is this realistic and desirable? Which structures, working groups, and so on will be required to support and implement national directives at a regional level? So, there's a lot of noise, there's a lot of questions to be answered, and today's webinar really aims to cut through some of this noise to better understand where we currently are and where we're headed with respect to the COVID-19 vaccination. So first up, massive thanks to our session sponsor, Santam. I think it's noteworthy that this session is being sponsored by Santam whilst being headlined by Discovery. These are two fierce rivals in the domestic insurance industry, yet neither of them hesitated for a second to collaborate on this event. And this is the type of spirit that I think we are going to need if we hope to get through this pandemic. So first up, massive thank you, Mr. John Lomberg, for your support. Tell us, John, why is this important for Santam?
Maybe let me just start by thanking Accelerate Cape Town for this platform and opportunity to engage around a very, very important topic, the role of the private sector in supporting government with the rollout of the COVID-19 vaccine and maintaining employee wellness beyond COVID-19. As a risk carrier, this for us is a no-brainer that we've got to lean in and engage around this topic. Because Santam has faced many crises in its 102-year history and has always emerged stronger and wiser for it. And we intend to achieve the same result with COVID-19. So the Santam Group, being the largest insurer in South Africa, when COVID struck, we ask ourselves, what role can we and should we play? So made a small contribution, 410 million, towards COVID relief efforts to help clients, to help intermediaries, help suppliers, and also to help contribute towards the Solidarity Fund. There were other ways in which we supported as well. For example, providing PPEs to frontline workers. I learned new words like video laryngoscopes to do incubation for clients. This we sponsored, and also a creation of face shields through partnerships with the University of Wits. So all of these were efforts in which we played a role as Santam to demonstrate that this issue affects everyone. It should be front and center as to how we as a company lean in and respond to this challenge, national challenge that is. So the fight against the coronavirus pandemic is a collective fight. And it calls for unity, patriotism, and deep sense of humanity for all South Africans. It's important that everyone gets vaccinated as quickly as possible in order to get our economy moving forward. This needs unity and collaboration, obviously. We need to set aside our differences across all spheres of society in order to overcome this pandemic. It's a no-brainer. And I heard the president talks about getting healthy together. I think it's upon all of us to work together to achieve this outcome. So organized business need to support government-led vaccination rollout programs to address this pandemic and to return our economy to be fully functional again. We need to coordinate resources to collaborate, share expertise between business, civil society, and government to address this issue. So we need to guard against disinformation, unpatriotic agendas, and communicate relevant information to our staff and provide critical decisions to all constituents around transparency in dealing with this virus. So, Ryan, again, this is a no-brainer. We are very privileged to be part of this conversation and to hear and see how we can hold hands with other corporates in working with government to address this. I'm really keen to hear from Dr. Ron Whelan as to thoughts what Business for South Africa has got in mind. Thank you.
Thank you, John. Yeah, so, just before we hand over to Ron, we'd like this to be an interactive session. So please do use the chat and Q&A functionality, add comments, questions throughout the presentation, and we'll try and address as many of those at the end of the session as time allows for. So moving swiftly along, we are absolutely honored to be joined today by Dr. Ronald Whelan to provide the Western Cape corporate business community with much needed insights into the national vaccination program. Dr. Whelan is the Chief Commercial Officer of Discovery Health and has extensive experience in clinical and corporate healthcare spanning more than 20 years and 25 countries globally. He's also the head of the Covid-19 vaccine work group for Business for South Africa, having obviously pulled the short straw. So on that note, Ron, good afternoon, welcome, and the floor is yours.
Yeah, many thanks, Ryan, and many thanks for the kind introduction there, John, too. As you rightly mentioned, it's been one of the upsides of the COVID pandemic is that we've had the privilege of working with different corporate partners, and I think it's been an eye-opening experience for us, and actually quite an enjoyable experience. So we're delighted to be collaborating with our colleagues at Santam this afternoon. I'm going to jump straight into the presentation. I'm going to try and move through the presentation quite quickly. I think if you've seen one of my presentations before, I try and keep them light and fluffy, keep them very visual, so that we're able to move to the discussion as quickly as possible. As Ryan mentions, my background is I'm a medical doctor by training. I've spent the vast majority of my career in corporate healthcare. I lead Discovery's COVID-19 response both internally and externally. And then my day job is Chief Commercial Officer at Discovery Health. But let's jump into the presentation. If you give me a second just to get this loaded up, and then we can get going. Okay, so we thought we'd cover 4 quick topics this afternoon. Firstly, a very brief update on the SS situation. We'll focus the discussion on vaccines and variants, and then we'll move into just a few slides on implication for business. So what's Discovery doing, and what are we seeing other businesses globally doing? Before we can kick off any COVID presentation, I think it's important to ground the presentation in some of the basic science around this. So this is an up-close and personal picture of the COVID virus, or the SARS-CoV-2 virus. And there's 3 important attributes you need to understand around the virus if you're going to understand how to combat the virus. The first thing is it's got this yellow RNA strand here, and this is really the coding mechanism for the virus. And you'll see that this code is made up of very, very tiny protein molecules. And that's the equivalent of DNA in our human bodies. Each one of these codes is responsible for producing different aspects of the virus. Same as our DNA, parts of our DNA create our ears, parts of our DNA create our eyes, our brain, our heart, and so on and so forth. Coronavirus works in a similar way. The way the virus works is it attaches to your cells in your body, then injects this RNA. The RNA then replicates and creates additional virus particles. So that's the first important ingredient. The second important ingredient around the coronavirus is this blue shell here. This is the outer shell. Typically in viruses, the shell is made out of protein, and protein is typically very hardy. That's why viruses often survive in environments for protracted periods of time. Coronavirus is quite interesting in that it's made up of both protein and lipids or fats. And that's the main reason that the coronavirus dissolves in soap, in that the soap penetrates the lipid core of this. And that's why soap and water works equivalent to alcohol in coronavirus. The third important feature, and we'll speak about this a little bit later in the presentation, is this spike on the outside. It's called the glycoprotein spike. The spike is really important for 2 reasons. Firstly, this is kind of the landing gear for the coronavirus. So the spike attaches to your cells. Think about a moon rover attaching to a moon landing. That's where it lands on your cells and then attaches there. The second reason it's important is all of the vaccines have been developed against the glycoprotein spike. So all of the vaccines target the glycoprotein spike and produce antibodies against that spike. So very, very important. And then I think perhaps to add a third reason this is important, this is where a lot of the variants have happened, is actually in the spike protein. This is a slide I put up often in my presentations, and everyone says to me, well, what's the point? No pun intended. The point on this is a needle, as we all know, a common sewing needle. The tip of a sewing needle is a millimeter in diameter, Just to make the point around the slide, on the tip of a needle, you can fit 10,000 coronavirus particles. So the particles on the previous slide, 10,000 of these can fit on the tip of the needle. So the coronavirus is a diameter of 100 nanometers, and 100 nanometers converts into 10,000 particles on the tip of a needle. And you can imagine if you were then to blow on the tip of that needle with 10,000 virus particles, what would happen? You would end up with this effect. So this is a dandelion. I think is gives you a good illustration of what would happen to those particles. They drift off into the air, and then they drop to the ground at some point. Of course, the particles are coated in respiratory droplets, and that's why they drop off at some point. So that's why we've had all of this debate around, is the coronavirus airborne or not? But I think the dandelion really illustrates for us the basic physics around this. So that's, I guess, the very, very quick medical and science lesson, and then we can jump into the rest of the presentation. So quick update on the SA situation. You're all aware of this. We've gone through 2 waves. This is wave 1, and then this is wave 2. What you'll see here is that wave 1 or wave 2 was 1.5 times the severity of wave 2. Oh, sorry, of wave 1. What is interesting about these trajectories is we had a much broader wave 2, and the reason we had a broader wave 2 is that the virus spread differently across the provinces. So we had kind of sequential spread across the provinces in wave 2, whereas in wave 1, we had all of the provinces almost affected simultaneously. This is a very, very tough time for us at Discovery. The last week in December, first week in January, your hospitals were running at your complete capacity. We were airlifting members from various parts of the country to other parts of the country, and we're really scrambling for hospital beds. Fortunately, we were able to get everyone who needed a hospital bed, and managed to get anyone who needed an ICU bed. The good news is we're obviously on the down, and you can see from the attack rate, 3 new infections per 100,000 population per day. And that attack rate is sort of hitting our troughs between wave 1 and wave 2, and as you're way back as far as May, you would be seeing those sorts of levels. So really good news, and hopefully it stays on the down. That picture is mirrored across the different provinces. So this is just the same chart as the previous chart, just blown out across the different provinces. And as you see from this picture here, the Western Cape there started spiking early in June last year, and I'm sure you all recall that the Western Cape really led the first wave outbreak. Then settled, and then came back and started reasonably early again. Of course, it was led by the Eastern Cape in the second wave rather than the Western Cape. What was interesting about the Western Cape outbreak is it was almost twice as severe as wave 1. So if you look at that grey trajectory there, the attack rates almost double wave 1 on a similar testing pattern. Often you've got to calibrate for testing. But once again, as per the previous slide, the good news is all of the provinces are down. If you look at the right-hand side of the page, they all look like they're sustainably down, and we certainly hope this lasts. What our actuaries are also telling us is that we estimate now during the course of wave 1 and wave 2, over 50% of South Africa has been infected with the coronavirus. So there's probably a good level of herd immunity. The only challenge, as you'll see in the slides to come, is that we had a different dominant variant in wave 1 versus wave 2. So wave 2, we had what's called the N501V2 variant, and then wave 1, we had a different variant. On the discovery experience, what you'll see from this page here is a significant uptick in daily hospital admissions between wave 1 and wave 2. And as I said in earlier slides, we really felt this peak. This December period is very, very tough for us. And that is about the peak of our hospital capacities, 520 new admissions a day for COVID. So we've kind of felt that peak there. Fortunately, we're now 80% down off the peak in daily hospital admissions. So we've gone from a peak of 520 new hospital admissions a day for COVID. We're down to just on about 100 new hospital admissions a day. And our ICU rates are down now as well, and ventilator rates are down as well. So it's certainly a much more sustainable situation at this stage. So that's a quick update on the South Africa situation. I'll jump into the meat of the topic around variants and vaccines. So it's important that we start out with variants because variants impact vaccines. And just to bring you up to speed around what's happening on the variant situation. The first thing I want to say is that variants actually happen regularly in viruses. So viruses have the opportunity to mutate with every single replication. Every time a virus replicates, it's got to recreate its code. And every time it recreates its code, there's a chance that it's going to reread. I use the example, if you think of a sentence that says, Emily went to the dentist, and then you change one letter in the sentence, an E in the Y for Emily, what do you end up with? You end up with Emil went to the dentist. That single change in the coding results in a fundamental change in how the virus works. Fortunately, most variants are completely inert. Every now and again, you get a variant that behaves more aberrantly. But this is a really interesting page, global tracking of variant, coronavirus variants, dating all the way back to December 2019, all the way through to the last few days. And as you'll see, we started out with sort of 19A, 19B variants, and then moved into quite a big patch around these 20B, 20C variants, and that lasted the better part of 2020. And then in the latter parts of 2020, we started picking up this orange variant here, the 501Y-V1, the 501Y-V2, and the 501Y-V3 started coming into the picture on this. But if you look at the left-hand axis here, you can see that we've had over 45 different mutations in the coronavirus during the last year. So variants have been common, will continue to be common going forward. As I said, most of them are inert. Every now and again, though, you pick up one that is less inert. What is a variant? And this is why you'll now understand why it's important to start with the science. You'll remember the RNA sequence on the first page, and you'll remember the glycoprotein spikes. The RNA sequence is divided into different parts of the coronavirus. And this particular red element here is responsible for the production of the glycoprotein spike. So what's happened is the current mutations is we've got a small mutation in this segment of the RNA in the coronavirus. And a double click on that segment speaks to it's called the B117 lineage. So this is an up close and personal of that particular sequence. And within that sequence, we've got a tiny mutation on the N501Y. It's called the N501Y mutation. So that's where the mutation has happened within that tiny sequence there, and it's impacted the glycoprotein spike. And for that reason, we've had three different versions of the 501Y mutation. So the first one we've had is a version 1, so 501Y-V1, or more commonly known as the UK variant. All right. We've then had the N501Y-V2, which is known as the South Africa variant, and the N501Y-V3, which has just been identified in Brazil as the Brazilian variant. So those are the three different versions of the 501Y variant. Actually quite easy if you think about it. Version 1, version 2, version 3. Very logical. The other nomenclature is the B117, B1351, and the P1. But I much prefer this. I think this speaks to the direct lineage on that. These variants could pop up anywhere. It doesn't mean that the 501Y-V2 would need to be exported from South Africa. In fact, what we found is that we found a 501YV2 manifest in the US and in the UK over the last few weeks. And those are not imported cases. So as a result of these mutations, you can end up with your self-manifested variants. I'm not going to run through any of this detail on this. This is very technical and will probably take us all day to get through. But I do want to highlight the transmissibility piece here. So you'll see the 501YV1, the UK variant, is 50% more transmissible. Whereas, in fact, we got a study out from 2 days back that has now indicated that the 501YV2 is not increasingly transmissible. So it looks like it has lower transmission rates. They both have similar mortality rates to the previous variants. What is concerning, however, is the vaccines generally are working against the N501YV1. So there is some diminishment in vaccine activity, but as you'll know from 2 weeks ago, we've now proven that the AstraZeneca vaccine has lost a lot of its efficacy against the 501YV2. So that's really, really material. So that's an overview, and then we're still learning a lot about the 501YV3 variant. Incidentally, and I'll just point out on this page, this nomenclature, the E484, otherwise known as the ERIC gene or the EEC gene, that seems to be the gene that's responsible for lower vaccine efficacy. And if you look at the Brazilian variant, you're starting to see the EEC gene pop up there as well, and it's likely that they're going to see a lower vaccine efficacy. The 501YV1 seems to have been preserved. So moving ahead, just to give you a picture of those 3 countries, the UK, South Africa, and Brazil, this is the manifestation of different variants across those different countries. So let's just take the other South Africa example here. You'll see that we had 20D as the dominant variant early last year. We then moved into 20B, which seems to have been responsible for our wave 1 spike. We had quite a lot of 20A before the other 20B was in the mix. And then in around about September, October last year, we started to see growth of the N501YV2. And this N501YV2 has been responsible for our second wave. You're seeing a similar pattern, although different variants across the UK, a 19A, 20A, 20D, 20B, and so on and so forth. And then the UK ended up with a 501YV1 that was responsible for their resurgence in the second wave. And have a look here at Brazil. Brazil now, the N501YV3 is somewhere around 40% of the cases in Brazil. So an interesting picture across the different countries. Let's try and find my page. And to illustrate how this played out in the UK, so all we've done here is we superimposed the variants on the UK infections and UK deaths. Quite an interesting analysis, and you'll see the deaths are in brown, and the blue is the infection rates. And it's quite clear to see that the 20D seems to have played quite a significant role. It may also have been lead in from the 19A variant way back last year in the UK. But the second wave picture is fascinating in the UK. You'll see that the UK was on the way up as a result of the 20E variant. They then went into quite a hard lockdown somewhere around the end of November last year, managed to get their infection rates down, and everyone thought they were going to continue to go down. But they bottom turned. And everyone was bemused by the bottom turn at the time. And the reason for the bottom turn, as you can see, is very clear, was the N501YV1 variant started to come into play. As you've seen from the previous slide, it's 50% more infectious. And as a result, the UK then went down and went up again, and had a very, very severe second wave, despite quite a very significant lockdown, a very, very hard lockdown. That gives you a sense on how virulent that 501YV1 was. South Africa's picture is also interesting. You can see from this page here, the 20B likely caused our first wave. There's our first wave, both death and infections. And then our second wave was conclusively caused by the N501YV2. You can see it manifested in about September, October. It then grew and grew and grew. And that's why we've had the significant second wave. So that's the underlying reason for these waves. Variants are driving these waves, and this is what we've got to be prepared for going forward. Variants, as I mentioned, are not uncommon. This is a global picture of variants, and as you see, all countries have got different strains and different variants. South Africa, wagon wheel there, you'll see that the US has different strains and different variants. It's just I did a presentation to a group of US investors a week before last, and they were really concerned about investing in South Africa. And I put up this page. I said, Dick, every country has got a challenge here with variants. And by the way, I was able to point out to them that they just identified the 501YV2 in the US. And in fact, what's interesting about the US at the moment is that the 501YV1 will be the dominant variant in the US by the middle of March. This is a significant challenge for the US, and there is a very real risk that they bottom turn and then going to a subsequent wave. The 501YV1 variant is also spreading aggressively across Europe at the moment, so will become the dominant variant in countries like Switzerland, Denmark. Already is the dominant variant in Portugal. So Europe and the US are certainly not out of the woods yet, and many countries are going to be facing variant challenges. Incidentally, there's the Brazilian variant, the 501YV3. So moving on to the real hot topic around vaccines, and I know our colleagues in the Western Cape are fascinated with the vaccine program, as are we up in Gauteng and nationally. So a quick update on vaccines. I'd like to start out with an image of what vaccines actually look like and what the basic economics of vaccines. So this is obviously the Moderna vaccine. As you see from this image here, there are 10 vials in a box, and there are 10 doses per vial. So you basically got 100 doses in this box of Moderna vaccine. Just to help you calculate the economics on that, the average Moderna dose trades at $30 a dose. So if you got $30 a dose, times 100 doses in a box, that means that this box costs you $3,000. And $3,000 on the prevailing exchange rate, and hopefully the exchange rate remains where it is today after the budget speech. This box of Moderna would cost you 45,000 Rand. It's the equivalent size of a box of your golf balls. Think about paying 45,000 Rand for a box of your golf balls. That's the Moderna economics. Pfizer's equally interesting, but for other reasons. So Pfizer comes in not a box of golf balls, but what I label a pizza box. This is exactly the same size as a pizza box in dimensions. What's interesting about the Pfizer vaccine is there are the equivalent of 975 doses in a box. So 975 doses in the Pfizer vaccine. That's material, because you all know that the Pfizer cold chain is quite complex. And if you've got 975 doses that you have to use within 4 to 5 days of thawing the doses from -70, you've got to move quickly on these doses. And ideally, you want to put Pfizer through your high volume vaccination sites, and that's what many countries like Israel, the UK, the US are doing, is they're putting this through mass vaccination sites. Incidentally, 975 doses, $10 a dose. That's roughly $10,000 for this box of your Pfizer vaccine. $10,000 times your current exchange rate, 150,000 Rand for this delightful pizza. So that's your Pfizer economics. Some really interesting models globally. We are in extensive discussions with many countries globally around their different vaccination rollout campaigns. This is an interesting image, and we've been in conversation with the UK already. This is a cathedral in the UK. They're vaccinating 700 people a day out of this cathedral. You can see it's a relatively simple setup. It's basically tables and chairs armed with a nurse and a nurse assistant. And then they have a very well-defined operational flow on this. We've learned a lot from the UK rollout program. The UK's got 200 hospitals in their program, 1,200 pharmacies, GP practices, and various other community health centers, and then they got 50 of these big vaccination sites. So lots to learn from the UK on their program. Here's another interesting example. The US has leveraged the NFL and football fields, as drive-through vaccination sites. This particular site can handle up to 2,000 vaccinations a day. The LA Dodgers Stadium in Los Angeles is able to get up to 3,000 and 4,000 vaccinations a day. And very impressive what the US has been able to do in their throughput capacity. And we're working on similar models in South Africa. So a blend of GPs, pharmacies, and then these mass vaccination sites, linking in the public and the private sector. We've got to be driving at this sort of scale to get our program done as well. I think you're probably all aware that the pipeline for vaccines is strong globally. So you'll see over 154 vaccines in preclinical development. We've got well over 50 vaccines in human clinical trials. And then we have a number of vaccines that are already approved for emergency use globally. I think it's an important point on this page is that the vaccines are approved for emergency use across all countries. So no vaccine has got formal approval and registration. They're all under emergency use. And the same would apply in South Africa. So no vaccines registered in South Africa. Any vaccine would come in under emergency use in Section 2021. Wanted to very briefly talk about vaccine efficacy. This is an interesting slide from the CDC. This is the efficacy of the flu vaccine, so the annual flu vaccine. And you can see that the flu vaccine varies year to year. The reason for that is every year we create a new flu vaccine. And the reason we create a new flu vaccine every year is that the flu strain changes every year. So scientists have to predict what the next year's flu strain is going to be. Sometimes they get it right, 60%. Sometimes they get it wrong, 10%. As a vaccine efficacy. But I like this slide in that our annual flu vaccine is somewhere around 40% efficacious. And when you calibrate that against what Pfizer's been able to do and Moderna's been able to do and the other manufacturers have been able to do, 95% efficacy for Pfizer, 94% for Moderna, 67% for 67% for AstraZeneca, 66% for J&J. I mean, these are just remarkable. The science that has been achieved this year is just unbelievable, and credit to the scientists across all of these major manufacturers. The challenge, obviously, is that the vaccines are proving less efficacious against the N501Y.V2 or South Africa variant. So you see the AstraZeneca vaccine, 22% efficacious. The J&J vaccine also dropped off a little bit, and then the Nova vaccine dropped off to just below 50%. But that's still good. I mean, 50%, you're getting 50% reduction in severe morbidity and mortality. That's not a terrible place to be. Of course, you'd like to be at 90s, but that's still a pretty good result. All indications are that we're waiting for trial results on Pfizer and Moderna. There are some indications that the N501Y.V2 reduces the antibody titers across those vaccines, but we need clinical trials to prove how effective they are. All of the conversations we've had with scientists in South Africa and globally, there's a high degree of confidence that these vaccines are going to remain quite effective. They'll definitely drop off against the new variant. But the reason these two work so well is they produce huge amounts of antibodies. They are very, very effective antibody producers. So any drop-off comes off quite a high base. Okay, these vaccines are working amazingly in other countries. This is just a great slide out of Israel. It just illustrates to you hospitalization rates for populations that have been vaccinated versus populations that haven't been vaccinated. So in Israel, they've vaccinated the vast majority of their population over the age of 60 and less so in the ages of 0 to 59. And you can see how the crocodile jaw is beginning to manifest in Israel. We're seeing similar results in many other countries now as well. So I think is your credit to the vaccine and vaccine efficacy, and very, very exciting results to watch. From a South Africa perspective, you'll all know we're going to drive a 3-phase response around the vaccine program. Phase 1, healthcare workers. Phase 2, essential workers and high-risk population groups. And then phase 3, all the rest of us. Broadly speaking, there's somewhere around 1.2, 1.3 million people in phase 1, 15 million in phase 2, and 22.5 million in phase 3, adding up to 14 million in total. And then we are able to estimate, or I wouldn't say estimate, we've calculated the number of doses required for each one of those phases, and are quite far advanced in sourcing doses for the supply. Have made significant inroads with J&J, Pfizer, and various other players. Our target is to get through phase 2 as soon as possible, and we really are trying to create energy around getting phase 2 done by the end of July, maybe the beginning of August. This is a rough view of the supply pipeline. This pipeline changes on a daily basis. I'm not going to spend enormous time on this other than to say, when you add up these doses that have been negotiated and in the process of being secured, you'll see that they quickly add up to somewhere around 40 million doses, which you would have seen on the previous page is roughly the doses we need. So we're busy working on locking in a Pfizer deal at the moment, locking in on a J&J deal. And as you'll see from this page, if you lock in Pfizer and J&J, you get excellent baseload volume. And then there's some other channels around your COVAX and the AU that can begin to come into play as well. So I'm going to spin through the section very briefly on business, just to give you an update on what Discovery is doing and some implications for our business. So our mantra has always been protect our people, protect our business, protect South Africa. We've lived and breathed that for the last year or so, and we've had various initiatives across these streams for the last year or so. I think in terms of protect our people, we're starting to look very closely at the research around risk of infection in home settings and office settings. This is a brand new piece of research published yesterday. I could not include it in the presentation today. It's such meaningful research out of the journal out of the JAMA journal, one of the leading medical journals. And I think what you'll see from this page is the risk-adjusted level of infection in a home environment is roughly the same as in an office environment. And we are certainly going to begin to use this research to guide our return to office policies. As of today, we are over 95% work from home, but I think we are feeling the need to reinvigorate some of our culture and connectivity. In terms of broader initiatives, I think we're looking at three themes. The first one, and this is work done by McKinsey. The first one, as alluded to on the previous page, we're looking at remote work models, so work from home models, agile models, flexible models. A lot of work happening on this front across our business. I'm sure it's happening across your business as well. Digitization is a huge trend, particularly around e-commerce. This is McKinsey data on 2 to 5 times growth in e-commerce. So we really are pivoting into an e-commerce direction. And then automation, we'd already been on the journey towards a lot of robotic processes and AI. So it's just a question of accelerating those journeys. This is a jump through this slide very briefly, an Indian slide, or a slide out of India, research out of India. I think it just illustrates how e-commerce has grown. So telemedicine has grown, food delivery has grown, general e-commerce has grown, grocery has grown, online learning 63% up. I mean, in the context, if this is happening in India, it's going to happen in South Africa. There's just no doubt. And I think many of us have felt this. Our telemedicine consults across Discovery are up about the same amount. It's been a fascinating thing to watch. And then to finish off with my busiest slide of the day, in true Discovery fashion, we are, my colleagues call this hyper innovation. On the back of COVID, we went into sort of an accelerated innovation cycle, and we have built products and services like crazy over the last year. It's been a really frenetic year, and a lot of those products and services will then move towards digitization, e-commerce, new ways of working. So if you want to know what has kept me busy the last year or so, together with the rest of the team at Discovery, it's all of these initiatives that are on the go. I'm sure you felt the same stuff. I know we've all been in the boat around innovation, and this should be nothing new for anyone else. So with that, I'm going to wrap it up there. As I said, a bit of a whirlwind tour through the world of COVID, starting out with, how does the virus work? What's the South Africa situation? What do variants mean? Where's the vaccine program? And then a few thoughts on your implications for business. Thank you for your time and attention.
Thanks, Ron. I thought there were some really interesting points you made. Just looking at the questions, first one coming through from Clinton. Thanks for that, Clinton. You mentioned that around 50% of the country has probably already been infected. Do you anticipate a third wave? And if so, what would sort of be the cautionary indicators to look out for ahead of a third wave, I guess?
Yeah. It's. I mean, let's start with the 50% question. There's been a lot of discussion in the media around the 50% question, and we'll move on to the implications of the third wave. I think what's interesting is it's very difficult to get a sense on actual infection levels and actual death levels when you look at the reported statistics. We just don't have accurate data on how many people have actually been infected. We don't have data on how many people have actually died. That's just the nature of the pandemic. But what we do have very reliable data on is excess mortality. And when you look at the excess mortality data, it looks like we've definitely had 120,000 excess deaths during the last year. There's no other obvious reason other than COVID. So actuaries have made some adjustments for the 120,000 excess deaths, and then converted that based on studies on actual mortality rates for COVID. So the actual mortality rate for COVID is about 0.28%. And if you divide 100,000 by 0.28%, you'll see you end up with somewhere around 24 odd million people who have potentially been infected. So that's the rationale behind that calculation. We've tested that with many of the scientists across South Africa, and I think have tested it against seroprevalence studies. There have been seroprevalence studies that have measured antibody levels in maternity populations. In fact, in your hometown, Kritisky did a very interesting study, and they found way back after wave one, 40% of maternity admissions tested positive for antibodies, which suggested they had previous infections. So that was back in August, September already. So that's I think it may well actually be more, but 50% is where our actual projections sit. Insofar as wave three is a very challenging question to answer. So you could take the view that says that most of the population's been infected, therefore we've got some level of herd immunity. That's one view in the world to take. What throws that into disarray is we have no idea how the variants will affect existing immunity levels. So how long will your immunity last? Will there be another variant that comes into play? So it's quite hard to project. It looks like we are reasonably stable on the variant front now, and if we stay stable on the variant front, and we've got the immunity is lasting immunity against the N501Y V2, then we should be in pretty good shape for a third wave, and hopefully we won't have a significant third wave. But if we see a new variant or the immunity doesn't last, we then have a very big risk of a third wave.
Here's an interesting one from Franklin. Thanks for that, Franklin. He says it's change of season and we might start seeing flu-like symptoms. How do we recover from the psychological fear that every cough or similar symptom could become? I mean, I can relate. I had an allergy and, was even sort of like a beer allergy, a wheat allergy. And, you're out in public and you have a little sip of beer and you start coughing and it looks like they want to forcefully remove you from the premises. So, I mean, is this going to just be with us for a while, or are there certain things that companies could do, messaging and so on, information programs and so on, that could at least, prevent people from beating each other up just for coughing in each other's presence?
Yeah, so I mean, great question. I think the first thing worth mentioning there is we didn't have flu last season. Flu basically disappeared from the globe, not only in South Africa, but globally last season. We had we watched the discovery data around flu very closely. The other place, we work very closely with the pathology groups who track flu strains. So they'll track the number of respiratory viruses during any flu season. When I say to you we had a handful of cases, I mean we had a handful of cases across discovery, and typically it's thousands and thousands of cases. And I think it indicates to you how flu is spread, right? If you're wearing a mask, actually you're preventing flu. And if you're doing good hand sanitization, you're preventing flu. And if you're social distancing, you're preventing flu. So it's been quite an interesting experience on the flu front. You're right insofar as that the flu symptoms are very similar to COVID symptoms and very hard to differentiate between the two. In this environment, everything that looks like flu is COVID until proven otherwise. I think that's got to be your mantra. If it looks like flu, feels like flu, it's COVID until proven otherwise, and then obviously all of the precautions come into place. I think the one thing that is conclusive insofar as COVID, not only in South Africa but globally, is we're going to be living with COVID for the rest of 2021 and probably into a bit of 2022 as well, which means that mask wearing, social distancing, and all those precautions that we've had in place across our workplaces, across our family lives, across schools will continue to remain in place.
Yeah, I do think though it's we need to start accepting personal responsibility for keeping ourselves and those around us safe, because we absolutely cannot afford another lockdown, I think, in this country, and it's going to be dependent on all of us sort of doing the necessary to try and limit that. Interesting question from Solly Furi. Thanks for that, Solly. What's your view on the country's ability to nationally roll out vaccine to all essential workers as defined in the Disaster Management Act? And what is the role of the business private sector in this rollout?
Yeah, excellent question. Thank you for that question, Solly. So there's two sides to the coin on this, Solly, and two pieces of the puzzle that you've got to solve simultaneously. The first piece of the puzzle you've got to solve is supply. So can you get enough vaccine stock? And then the second piece of the puzzle, and very, very closely linked to that first piece, is throughput capacity. So it's one thing landing 6 million doses of vaccine in South Africa on a monthly basis, and an entirely different thing consuming 6 million doses a month. When you convert 6 or 7 million doses a month, it converts into somewhere around 250,000 to 300,000 vaccinations a day. 250,000 to 300,000 vaccinations a day. That is a big chunk of work, and requires a concerted effort from both the public sector and the private sector. Neither could do it alone. So the public sector could not do that cadence alone, and nor could the private sector do that cadence alone. Private sector can. Our estimates is the private sector could vaccinate at somewhere around 140, 150,000 vaccinations a day, and then the balance would be picked up by the public sector. So we're doing extensive work from a B4SA perspective, as well as from a discovery perspective, on getting the private sector ready, supporting the government, get the public sector ready for this mass throughput capacity. Pharmacies, GP practice, mass vaccination centers, hospitals, occupational health sites, everything's got to come into the mix so that those centers are ready for when vaccines really arrive en masse. As I said, the supply side is looking increasingly positive. We have two very good deals on the table with J&J and Pfizer. So J&J, as you know, is part of the initial rollout. We're going to expand the J&J campaign now over time, and there are additional J&J doses that we're busy working on, both from an NDOH perspective as well as from a BSA perspective, and you're working collaboratively around those negotiations. And then Pfizer, we have a number of doses that we're on the verge of securing and signing contracts on. These are extremely complicated contracts. I can't overemphasize how complicated these contracts are. They 100-page agreements. They come directly out of the US, and you can imagine the legalese around those contracts. In addition to that, they have a very tricky indemnification clauses. So the J&J contract, for example, requires national government indemnification of the entire vaccination program for adverse events. So they require you to have a national fund that will reimburse on any adverse event. This is unprecedented in medical world and vaccine world. So complicated stuff. I think maybe, Sally, to answer your question very directly around your healthcare workers, and it sounds like you're in that space. The healthcare worker campaign will continue to speed up in momentum, and I think it's been an amazing pivot that we've been able to switch from AstraZeneca to J&J in no more than a week and a half. It was it's really an incredible pivot. We're now on the scorecard, beginning to ramp up. The next round of J&J doses are soon. We're starting to open up the pipeline in commercial J&J doses, which will come into the mix during probably during April. We've also got some Pfizer doses that should begin to come into the mix now to supplement the J&J program. So I'm hopeful that the conveyor belt is starting to move and starting to pick up pace, and we certainly want to get healthcare workers vaccinated fast.
Questions are flying in. I'm afraid we're running very rapidly out of time. But something that I think is on the mind of lots of business in this region, given some of the messaging we've been exposed to, is regional, given what you've just said around the challenges of actually securing vaccine and the guarantees and so on that needs to be put up, is regional autonomy an option? So, talk of a Western Cape vaccination plan. Is that realistic?
Yeah, I think it's a great question. I mean, we're obviously following the reports here closely. From the Premier and the Western Cape. We're also following some of the private sector reports, and have been in conversations with Neil Foneman, for example, from Sibanye. I guess anything is possible, and there's always ways and means around things. Yes, at least from our perspective, two things here prevail. I think the first one, and very importantly, the only way this program is effective is if everyone gets vaccinated. If we don't get everyone vaccinated, we don't achieve herd immunity. And then what actually happens is we achieve immune escape. So what happens is you have increased risk of new variants if you have some people vaccinated and other people not vaccinated. And I think we've seen that the virus travels across provinces. You saw that happen in December, Garden Route, Eastern Cape, and so on and so forth. So there's no isolated province. So that's, I think, the one is from a clinical perspective, you've got to drive mass herd immunity. I think the second thing is from an equity perspective, and we feel strongly about this, in that it doesn't seem fair for a young 30-year-old with means to get vaccinated before an older, a 70-year-old without means. That just doesn't make sense. The 70-year-old without means has a multiple of risk of severe disease, morbidity, and mortality. And I think just as a populace, that doesn't seem constitutionally right to us. And then I think the third piece around this is there's some significant regulatory issues to get through. So you've got to get the vaccine registered. You've got to have an import license. You've got to have this national indemnity in place. It is complicated terrain. These are very sensitive substances that at the end of the day are medical products. They get injected into human beings. There are medical legal risks around this. So this is not something you necessarily want to pick up likely certainly as a private enterprise.
Thanks for that. Certainly that was my sense as well. We're in this together as a country, and any resources that are available in any particular region should really, in my view, be applied towards the national effort in a coordinated fashion, so that, as you said, we can get everybody vaccinated as quickly as possible. But what about costs and funding of the vaccines? Is that likely to be an issue? How will vaccinations be paid for?
Yeah, I think the first thing worth mentioning there, Ryan, is that the vaccine program in relative terms is very affordable. So all estimates are that the cost of the overall program rollout, including vaccines and vaccination, is somewhere in the order of 10.5 to 12.5 billion rand. And 10.5 to 12.5 billion rand against 2 trillion rand fiscus or revenue collections, like that's a pretty small investment to make. I think also worth mentioning is when you compare the vaccine program to the cost of testing. So South Africa spends in the order of 6 to 7 billion rand on COVID testing alone every year. 12 billion rand sounds like a good investment. In terms of how it will be funded, so it will initially be funded centrally. So National Treasury will procure the National Department of Health will procure the vaccines funded by National Treasury. The vaccines will then be distributed free of charge into the public sector, and they will then be distributed. They will be sold into the private sector to enable medical aids then to fund the vaccine through the private sector. So what it nets out is the 12.5 billion total program cost then basically becomes a portion funded by National Treasury and a portion funded by medical schemes. Medical schemes are obliged to fund for the vaccine given it's now prescribed minimum benefits. So there's a legal obligation for medical schemes to fund for the vaccine. From a consumer perspective, whether you're in the public sector or a medical scheme member, you will receive the vaccine free of charge.
That's great news. I mean, it's basically an SAA bailout, right? So it shouldn't be. We see how easily that money can be found. So it shouldn't be too much of a challenge to get everybody vaccinated. Very quickly, running out of time. Just very quickly, in terms of expected timelines and key factors impacting on timelines. I mean, you've mentioned that it's a challenge sort of getting supply of vaccine, and then obviously the rollout. What are sort of our expectations in that regard in terms of firstly the supply, and then obviously I think we would need to activate regions and provinces and so on to actually get it rolled out. But your sense in terms of sort of timeline for all of that?
Yeah, great question. I mean, I get asked this question quite a lot, and it depends a little bit. I think what we're aiming for, as I mentioned in the presentation, is first prize as we get through phase 2 by the middle of winter. So by the end of July, we've got through phase 2. In fact, that's no mean feat, by the way. Yeah, that's close to 16 million people that we need to vaccinate. That is a big target. And then the balance of the population and the remainder of the year. So that is what we're gunning for as B4SA. That's what the Department of Health is now gunning for as well. And that's sort of our initial timeline. To get there, as I mentioned, we need supply of vaccine, and then most importantly now, and we've pivoted a lot of energy towards creating throughput capacity, so making sure we're actually able to consume that volume of vaccine. That's really where a lot of the time and attention is now moving, is into that throughput capacity front. Still got some work to do to secure vaccines, but that is looking certainly more robust and promising, and the pipeline is opening up globally.
Fantastic. I mean, it might seem like a silly question, but these are some big numbers. What about things like needles and all the associated equipment that would be required for this vaccine? Are we well placed as South African, as a country?
Yeah, great question. So the needles and the consumables and the alcohol swabs are all priced into that. So it's a very, very detailed costing model, very impressive costing model. Where there is some opportunity though is on the Pfizer front. There are some specialized needles that help you optimize the doses in the Pfizer vial. And so instead of getting 6 doses, you can get, instead of getting 5 doses, you can get 6 doses out of a vial. And if you think about $10 a dose, you can get an extra dose. You don't mind spending a little bit more money on a syringe that's specialized for that. But no issue on consumables, and we certainly got the supply chain working on consumables. But it is a risk and well asked.
Fantastic. Unfortunately, we've run out of time. We're not going to get to all of the questions, but thank you everybody for your attention. Thank you very much, Ron. We really appreciate you coming out today and to Discovery as well, and for the insights that you've afforded us. I mean, I think certainly for me, it's a lot clearer, and certainly the way forward looks a lot clearer. Also, massive thanks to John Lomberg and Santam for your support today. And then, just to close out, a little quote from the Santam CEO, Lizay Lamprecht, which I think summarizes all of this. And she said, "The fight against the coronavirus pandemic is a collective fight that calls for unity, patriotism, and a deep sense of humanity from all South Africans." I don't think anyone could have said it better than that, and it sums it up beautifully. So on that note, thank you everyone for your time. Thank you for your attention. And we look forward to engaging you more as we all try and track this moving target going forward. But we are certainly all in this together, and I'm certain we'll prevail. Thank you very much. Thanks, Ron. Have a fantastic day. Keep up. Bye-bye, everyone.